hard work, okay, sharing with me and with us, please, with all of us, those practice questions that are very good, okay? So I'm going to take the advantage of this, the availability of this question to continue discussing pertinent topic with you that are very possible present in your Nclex. Thank you, Mayra. The nurse.
You're welcome.
Thank you, Mil. The nurse is caring for a client during the second stage of labor when shoulder dystocia develops. So second stage of labor is when the 10 centimeters of dilation of the cervix have been already reached and the baby should come out. So it starts when 10 centimeters have reached and ends when all the baby is out. But a problem appears. The head is out, but the shoulders get stuck in the pelvis. You are going to see a sign called the turtle sign. Turtle, like the animal, can project or protrude the head out with the neck, but then can retract back, can hide back the head. This is what happens when the shoulder get stuck between the pelvis, okay, between the pubis and the sacral bone. Which of the following actions should the nurse take? So read the options and tell me what you would answer if you were in your Nclex.
B, number 2.
Okay. Why number 2? What you know about this?
Because by pushing her thighs to her abdomen, it's gonna open more the pelvis for the mom, and it's gonna let the baby be out.
Yes, I agree with you. This is called the Mcrober's maneuver. And when we hyperflex, let me share a picture with you. Let me open my PowerPoint. Let me go here. Okay, when you have this situation of pelvis, shoulder dystocia, where is it, Beijing? Okay, here it is. Okay, it's because the shoulders get stuck between the pubis, which is this bone. Let me hands. Okay, so this bone is the pubis, and this is the sacrum. So the shoulder gets stuck there. So the head is out, but the shoulder cannot go out. So each time comes a contraction, the head and the neck protrudes like a turtle. But then when the contraction subsides, the head, return back because the shoulder cannot go out. If you move this pubis to this position, to here is the pubis in the lithotomy position, in the normal position to have a baby. But if you move this pubis in this direction, hyperflexing the hips, so moving the thighs to the abdomen, this is the Mcrober's maneuver, then it is going to probably help to remove the baby. Okay, so that's good, very good. So if you didn't know that, now you know it. So now you know it. Okay, so this is. The other options are not correct in this situation. You cannot ambulate a woman that has the head of the baby out of the vagina, please. And making pressure in the client's uterine fundus, what can produce is a fracture of the shoulder of the clavicle of the baby or a rupture of the uterus. And if the head is out, of course, the cervix is already dilated. So if it is in the second stage, it's redundant, this option, because it is assumed that the cervix is totally dilated. Okay. I don't know, but it's not moving. I need to go back to here. Sorry. Here. And then go to the next one. Okay, good. The nurse on a psychiatric unit is alone at the nurse station when the following 4 clients simultaneously requested assistance. Which one would be a priority for the nurse to assist? Read the 4 options. Tell me what you think is the priority here.
Three.
Why 3? What are you thinking with 3?
Delirium tremors.
Delirium tremors. This is the right answer. The patient is having a delirium tremors and alcohol withdrawal, and it is a life-threatening condition. You need to be aware that delirium tremors has a very huge high mortality. And yes, this is a physical issue. It's not psychiatric. It's not. It's in the base of the Maslow pyramid. Okay, the situation of the delirium tremors. So remember that alcoholics clients used to drink every day. When for any condition are hospitalized, then and then they don't receive alcohol in the hospital, is frequent to develop late, like 2-3 days after the admission, these conditions. A characteristic is the activation of the sympathetic nervous system, so there is tachycardia and hypertension. And classically, the patient is having a lot of tremor. You know that alcoholics will, while in withdrawal, they shake a lot, okay? And profuse sweating is characteristic also. But the most important, the alteration of the mental status with visual and kinesthetic, okay, hallucinations. They see visual bugs in the walls, and they feel kinesthetic in their skin. They feel, okay, bugs crawling on the skin. So this is the absolute priority. The other clients have psychological needs. Like this patient that is having a grandiosity delirium, okay, because is feeling that can pay for the cruise fare for everybody. Is probably a maniac client. It's a grandiosity delusion. And this one that is having hallucination, auditive hallucination, and has paranoia. And this one that is having anxiety. This is the priority. Very good, very good. Okay, again, okay, be aware that Nclex wants you to identify alcohol withdrawal as a priority and to know how to treat it with benzodiazepines, no? And don't forget the glucose and the vitamins. The nurse is planning a staff education conference about caring for clients who are scheduled for thoracentesis. Which of the following information should the nurse include? Okay, so read the options and tell me what you think. Okay, I noticed that it's bringing a little difficulty. Let me call my no sé cómo voy a hacer. My what? My pen. Okay. So no, I cannot use that there. Okay, sorry. No, I cannot use this there. I'm thinking what to do. I cannot use. Okay, maybe what is this? What is this? I don't know what is this. It's a filter. Sorry, just a moment. Oh, good. Oh, yes, I have a pen here. Pen. Okay, pen. Chévere. Okay, so what we can eliminate here? Tell me, what we can eliminate here?
4.
4 is nonsense. So There is nothing to
three.
do. And three.
Three.
Yeah, and three also, because the
Yes.
position during the procedure is sitting, resting the arms in an overbed table. No, you need to have an overbed table, okay, or anything similar where the patient can rest the arms probably on the pillow, but need to be totally upright. So the lung has the liquid going down in the most dependent part and is easy to penetrate here with a syringe with minimum risk of piercing the lung because the thick layer of liquid that accumulates in lower part. So definitely it's between the X-ray before and the ABGs after. What do you think?
I select number one, but I wasn't sure about that one.
Yes, makes sense. I'm not totally sure neither, but I say what I expect with the ABGs, what I expect happen with the ABGs, at least with the oxygenation after the procedure, improvement. Okay, so I expect 1% of improvement of ABGs after the procedure. That's why it's not indicated, it's not usual, it's not part of the protocol of the thoracic tissue to do an ABGs to see how is the PO2 after the procedure. Because my logic say the procedure should improve the oxygenation of the client because you're not removing the pressure of the liquid that tends to collapse the lung will produce more expansion of the lungs and improvement of the oxygenation. What is important is to avoid introducing a needle in the pleural space where liquid is not present, because if a needle is introduced in the pleural space without liquid, then the one that is going to be penetrated, going to be pierced is the lung, and then a pneumothorax will be produced. Okay, so it's important for the the provider to have an X-ray that confirms that is liquid in the pleural space, and it justifies the thoracentesis. I think that I agree with you that if I were in my Nclex, I prefer to choose one except two. But this is the systematization, the way that you should be, answering this question. Mira qué bueno descubrí que hay lapicito. Yo sin lapicito no puedo enseñar. Okay. Okay, the next one. Okay. The nurse is caring for a client who is receiving cardiac monitorization, and this rhythm is shown. Which of the following should the nurse anticipate they will be prescribed for the client? What do you think is the answer to this?
Number one.
4.
Okay, okay, let's go to number one. Number one is indicated when you have a tachycardia, something rapid, generally supraventricular tachycardia, that is something like this. So very rapid, okay? A supraventricular tachycardia, very rapid, and it is justified cardioversion because any other maneuver have failed, or when you have an atrial fibrillation, and the doctor decide to convert the client to normal sinus rhythm, an atrial fibrillation. Okay, I don't know what I'm doing here because I'm not having control of that, but an atrial fibrillation and supraventricular tachycardia. Okay, supraventricular tachycardia are indication of cardioversion. The cardioversion is synchronized and requires sedation because the patient is conscious. And it's different from the defibrillation because defibrillation is reserved for the BTAC or for the ventricular fibrillation. Yes. And so no. The next time you think in cardioversion, think in a patient that is ¿cómo se llama? With a supraventricular tachycardia or atrial fibrillation or atrial flutter. So an atrial dysrhythmia. Dysrhythmia is abnormal rhythm. Tachy, rapid. Atrial is supraventricular, no? So think in cardioversion for those rhythm. This is not a rapid rhythm. I want you to try to remember this number, 3 through 5. When you count the big boxes, you know, this is a big box, this is another, this is another. So you can count the big boxes. The number of big boxes that should be between one QRS and the next should be between 3 and 5. So minimum 3, maximum 5. If it is less than 3, so let's see 2, yeah, 2, it is a tachycardia. Suppose that the blue lines are QRS. So they are 2 or near. Okay, so less than 3 is 2 or 1. Yes, this is a tachycardia. So when there is less than 3, it's a tachycardia. Okay, but when ya va que no sé cómo va. Significa. Ya va, un segundito. Hago yo. Okay, no puedo. Okay, and if you have 5, 1, 2, 3, 4, 5, more than 5, 6, 7, 8, it is a bradycardia. It's a bradycardia. ¿Cómo voy a bajar esto allí? Something. Just a moment, guys, because I'm fighting with the. I'm going to close this. Still is not. I'm going to close this. Still is not. Okay. Okay, so as you note here, you are having a bradycardia, no? A bradycardia, yes. So because there are more than 5, no? More than 5. Yeah. And somebody said pacemaker. Okay, so the only possible option here is a pacemaker. Why? Cardioversion is not indicated. You have nothing, any dysrhythmia to shock. Vagal stimulation is going to make the situation worse because vagal stimulation slows down the heart rate. Defibrillation is not indicated because, you know, this patient is not in neither in ventricular fibrillation nor ventricular tachycardia. So the only possible option is pacemaker therapy. The question is tricky because in reality, it is a sinus bradycardia. Why I say a sinus bradycardia? Because I see P wave before each QRS with a PR interval that is normal and a P wave that, you know, is normal. So it's a sinus bradycardia. If I were the person who write question in the Nclex, I put, instead of pacemaker, okay, I put find out which medication is taking the client. Because if it is dioxin, it is a ditch toxicity. It is a beta blocker, it is need to be reduced the dose because it's to slow the rhythm. You understand? So any doubt, any question? Can I help in any extra way?
Professor, I have a question.
Sure.
A sinus bradycardia can be normal also in certain
It can be
persons.
normal, but in an athlete, in ¿cómo se llama este? LeBron. Okay, but you know, I saw so few labrums in United States. So don't assume that the exception of the rules are the stuff that is going to guide you in a nursing test. Okay, the most common is what I mentioned, medication. And I saw this question in Nclex, okay? A patient with a sinus bradycardia, which is the most important you need to find. Medication, which medication the patient is receiving. Because you can do nothing with Lebron, okay? Just, okay, admire him. But you can do something in this toxicity or in too much dose of beta blocker. You understand? So that's why is the question that I anticipate you can have in your Nclex. Trying to imagine alternative to this stuff. Definitively, if this is an asymptomatic bradycardia in an athlete, doesn't require any treatment. But you know, those are the exception of the rule. Who is such a high performance athlete as to have this bradycardia and being asymptomatic? Yes, James LeBron. Okay, but you know, the anchors go to the people that are sick. Don't go to the to the athletes. That's why you need to always be thinking in what is the most probable question you have. So now, do you agree with me? Everybody's clear that the best option here is by default pacemaker. If the patient is symptomatic, then the patient will be placed a pacemaker. But I anticipate, and I think this question cannot be in Nclex with this EKG because it's sinus bradycardia. And sinus bradycardia, the most important is to see if drug action. And if it is because overtraining, because you know, there is no absolute indication of pacemaker. But I need that everybody understanding that we need to survive. If we have bad luck, a question like this, we don't go in detail and we say this is in a slow rhythm. So summarizing, what you can keep for your anchors. Remember, this 3 to 5 is very useful because in Nclex they put the EKG strips like this without any other way of doing that except doing calculations, and it's going to consume time. 3 to 5. It is less than 3 is a tachycardia. More than 5 is the bradycardia. Obviously, the number of big boxes that you have between these TQRS is more than 5. So it is a bradycardia. So when there is a bradycardia, the heart is beating so slow that now not too much blood with oxygen reaches the penthouse, the last floor of the building, which is the brain, no? And the patient can pass out. Pass out is called syncope. And this is the indication of the pacemaker, okay? And to speed up the heart. Yes. If they were asking about medication, of course, you go to the anticholinergic medication like atropine. Yes. What is contraindicated is CACA, is no, beta blockers, calcium channel blockers, dioxin, because they slow down the heart. All those are possible questions related with this scenario that you need to master going to the Nclex. If you give a beta blocker, if you give dioxin, if you give a calcium channel blocker, non-dehydropyridine like diltiazem or verapamil to this client, you kill the client. And then you can fail the Nclex. If you give atropine, the patient improves. If you give an adrenergic like isoproterenol, okay, the patient improves because the adrenergic speed up the heart, the same as the atropine. But pacemaker tends to be the definitive solution if the patient has a significant bradycardia and is symptomatic. Okay. No, there is no indication of cardioversion, not indication of defibrillation. There is nothing to shock there. There is anything to shock there, any a rapid abnormal rhythm to shock there at all. So can be, and if you select vagal stimulation, you kill the patient because, you know, it's going to slow down even more the heart rate. So this is what you can, learn from this question. ¿Cuál es la tercera? Ahí viene la cuarta. No, me equivoqué. La quinta. Okay. The nurse is assessing a newborn in the delivery room. Which of the following findings will require follow-up? Positive startled reflex, which is the same as motor reflex. Mild respiratory grunting, heart rate 110. Persisting blue discoloration, the hands and feet, which is also called acrocyanosis. What do you think is the answer?
2.
Yes. 2 is a sign of respiratory distress. Okay. The sign of respiratory distress in newborns are grunting. Grunting is a sound that they do when they breathe out. They breathe out and they say they begin something like and you can hear that. Okay. And okay, let me again show that because it is something that is important. Respiratory. Okay, I think I have that here. Oh yes, here is. Okay, so the other grunting is one of them. The other signs that can be asked with the same meaning, because it's not only grunting, even can be a cellular apply, is flare nostrils. When a person is breathing normally, or baby is normally breathing, doesn't need to open the nostrils during inspiration. But if you notice that during each inspiration, the baby opened, okay, the nostrils, and it is called flared nostrils, as you see here, okay, it is a sign of respiratory distress. The same as the grunting, the sound that I mentioned before. Intercostal retraction, you can see that here, that is the soft tissue between the ribs sunk during inspiration. It's a sign of respiratory distress. This subcostal groove, this subcostal separation with retraction or sinking of the xiphoid process in the chest and between the chest and the abdomen is another sign of respiratory distress. And it is also frequently tested. The seesaw, I hope that you know what is a seesaw. Seesaw is this stuff that is in the park, you know, sorry. That is in the park, you know, that, you know, that you have one child, okay, here, okay, another child here, okay. Okay, a seesaw, okay? Seesaw paradoxical respiration. Normally, when a baby is breathing and there is an inspiration or breathing in, the chest goes up and the abdomen goes up at the same time. When the baby breathes out, okay, breathe out, expiration, the chest goes down and the abdomen goes down. Okay, this is the normal. In case of respiratory distress, then a paradoxical seesaw movement occurs. When the baby is breathing out, the chest sinks, so goes down, and the ¿cómo se llama? The abdomen goes up. Okay, the abdomen goes up and the chest goes down, and vice versa. When breathing out, the chest goes up and the abdomen goes down. So it's a seesaw, like in the park. Okay, so those are signs of respiratory distress. Absolutely, absolutely. Otra vez se quedó pegado. Okay, absolutely. ¿Qué pasó allí? ¿Por qué se te perdieron?
Prof, I have a question with that one.
Sure.
I choose that one, the grunting, but it make me thought about the persistent. You see that the number 4 says persistent blue discoloration.
Okay,
So for
yes,
how long?
can be persistent as far as the baby is cold the baby is expected to have the acrocyanosis. Acrocyanosis is expected, is not a critical sign in newborns in the first, 72 hours of life. What you should think when you see acrocyanosis, the baby is okay. But what you need to do is to put the baby in contact with the mother's skin, or swaddle the baby with a blanket, because the baby is cold.
Yes, I use those ones to get rid of the number 4, but it make me thought a little bit about persistent.
It's persistent because it's going to persist the first week of life. Let me see si yo consigo regresar a esto. Más perdido que el hijo de Inver. Se me fue. Just a moment, guys. Okay, downloads. This is. Okay, it is. Okay, the heart rate is normal for a newborn. The heart rate in after birth is between 100 and 160. And the startle reflex is expected also. So remember that the acrocyanosis is expected in newborns the first days of birth. And what you need to think is it is not critical. It is cold. And when the cyanosis is around the lips and the mucosa is when it is concerning. So it is this kind of cyanosis called peripheral cyanosis. The concerning is the central cyanosis, the one that is observed in the mucosa and around the lips. Okay, I return to the normality. Very good. Y aquí, sí, aquí arriba está. Okay. The nurse is assessing a client with heart failure who is receiving prescribed furosemide. Which of the following findings should be a priority to follow up? Read the options and tell me what you think.
Two.
What are you thinking when you select 2? What are you thinking could be behind that?
Some kind of electronic imbalance.
Like what?
Low potassium?
Low potassium. Low potassium. Because this is what furosemide makes. No? Furosemide lowers potassium, sodium, and chloride. The sodium is normal, so it's not the sodium. So what is left in our imagination is the potassium. No? And potassium, low potassium produces muscle weakness. Okay, the muscle contraction decreases. So it is obviously the most concerning. The sodium is normal, so it is not the issue. The blood pressure is acceptable. The furosemide can elevate the uric acid, but is not priority over hypokalemia. The nausea is of difficult interpretation, but if we start overthinking that the possibility of the patient being in heart failure taking digoxin could be another element in favor to select this option, but without overthinking, without need of going beyond what is already written. Furosemide, low potassium is the main side effects. Muscle weakness, low potassium. So you have the 2 conditions. So I also would select this option in my Nclex. The nurse is caring for assigned clients. it will be most important for the nurse to monitor. Don't forget the superlative, most, first, next, most important, etc., etc. Serum lipase for a client with high cholesterol, hypercholesterolemia. ABGs in a client with acid-base imbalance. Serum glucose in a client with diabetes insipidus. And ACTH level in a client with fluid imbalance. It is easy. What do you select?
2.
Okay, you say 2? Okay, perfect. I agree with you. Obviously, it's the only one that is properly paired because lipase is not needed in client with hypercholesterolemia. Lipase is needed in client with pancreatitis. Glucose levels are important in patients with diabetes mellitus, not diabetes insipidus. And the ACTH is expected to be abnormally elevated in certain fluid imbalances, like hypotension, stress, okay, low sodium, etc. So it is something expected. It's physiological. So what, no doubt, that is important to monitor if you have a patient with an acidosis or alkalosis. Monitoring the ABGs is the most important test. So this is a correctly paired, okay, test. These kind of questions are very common in English, okay? If you know how to pair test to disease or medications with diseases, you know, it is a very common style question in English. Cancel. That's why I'm making, okay, products, okay. The nurse is reviewing lab results in a client with rheumatoid arthritis who has a new prescription of NSAID. Which of the following test result will require follow-up prior to administering the medication? Ignore the mark because there are many questions that are wrongly answered. Serum glucose elevated, serum creatinine elevated, white blood cell count elevated, and platelet counts, which is normal, but in the lower limit.
2 is made.
So I understood that you said number 2 on creatinine, no? Okay. If you selected that, you are in the correct, okay? The NSAIDs are nephrotoxic. So it's an important concept that you need to carry. NSAIDs classically are remembered as being toxic for the stomach mucosa, producing ulcers and GI bleeding. But sometimes we forget that NSAIDs are also nephrotoxic and are contraindicated in people with renal damage or people at risk of having renal damage with, like, old people or people that are dehydrated, etc. No doubt that this is the important one, so an easy one. The nurse is wearing clean gloves, as well as a protective gown, so gowns and gloves, and has placed a stethoscope in the client's room to be used only with this client. Which of the following clients is the nurse prepared to care for? Select all that apply. Okay, so I'm sorry. Okay, yeah. TV, yes or not?
No.
What we need for TV?
Evo precaution.
N95.
N95. The PPE, the N95. Disseminated herpes zoster, yes or not? Gown.
Yes.
So, and what else do we need in disseminated herpes zoster?
N95.
N95 also, okay? But the fact that they don't mention N95 doesn't disqualify the order, the option. They are saying, okay, the nurse is wearing gloves and gown, okay? And, dedicated instrument, okay? So they, in any moment, they are saying that the nurse is not wearing N95. But for disseminated herpes zoster, which is airborne and contact, you need gloves, you need gowns, and an N95. So I agree with you. I mark that because it doesn't contradict the fact that is also needing N95 doesn't contradict that what is stated. In any moment, the options say that the questions say that the client, the nurse is not using is not using an N95, so no problem with that. Okay. Streptococcal pharyngitis. What's up?
It's a droplet, so it
It's
will
a
be
droplet. It's the S of Spider-Man, yes? It's the S of Spider-Man. So what you need, a regular surgical mask, but you don't need gowns and gloves. But how long is going to last this isolation?
24 hours until
After
start
initiating
antibiotics.
antibiotics. Very good, because it's also tested. Remember that in case of streptococcal pharyngitis, the isolation is discontinued after 24 hours of antibiotics. Okay, it's tested. It applies also for meningitis. It applies for pediculosis, for scabies. Okay. Those are conditions that they test. Okay, it's correct to put the clients in isolation because it's contagious, but how long? And in 24 hours, these isolations are discontinued after initiating the treatment. Okay, a patient with HIV requires gowns, gloves, and dedicated stethoscope?
No.
No.
No, because it's a standard precaution. And herpes simplex, a client hospitalized with herpes simplex?
Yes.
Yes, this is pure contact. So absolutely good. Okay, so what we need to learn here that we need to study very well, like the people that are answering infection control, because it's a super high yield for your test. The nurse, no, another one. The nurse is caring for a client who has Clostridium difficile, C. diff. Which of the following infection control precautions should the nurse implement so that apply? Place a stethoscope. So let's establish Clostridium difficile is contact. Yeah. So place a stethoscope in the client room to be used with this client only? Yes.
Yes.
We said that before. Use alcohol-based hand rub prior to and after any client contact?
No.
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 In the case of C. diff, being C. diff, a bacteria that can survive with spores, we cannot use alcohol-based hand sanitizer because the spores are not killed by alcohol. So need to be mechanically washed away with soap and water. So alcohol based hand sanitizer is okay to be used before and after contact with the client, as far it is not a sport-like disease like Clostridium difficile. And of course, when they're not visibly soiled, hands. Wear a protective gowns and gloves when providing care. It is contact, yes. Place a surgical mask on the client during transport out of the client room.
No.
No.
It is correct, but clients with droplet or airborne, both droplets and airborne, is correct to place a regular surgical mask on the client if the client need to leave his or her isolation room for both droplet and airborne. So tuberculosis and meningitis, mask, regular mask, not N95, regular mask on the client, when leaving, going out the isolation room. Place a client in a private room with another client infected with the same organism?
Yes.
Yes, because if they state that is the same organism, then there is no problem. We can cohort if we have proof that is the same organism. So we don't discuss with this option. Perfect. The reality is that this situation is very rare, but we don't, if they say that it's the same, we accept it's the same. The nurse has taught the family member of a client with Parkinson's disease. Which of the following statements by the family member would indicate a correct understanding of the teaching? What is correct here?
I wasn't sure about that one. I picked two, but I'm not sure.
Any other person has opinion? No? Okay, let's see if I were wearing Nclex with a similar situation. We are not sure what we can do. Let's eliminate the one that can be eliminated. Which one you can eliminate?
1 and 3.
One is nonsense. You know that Parkinson's produces dysphagia, but then the liquids need to be thick, not thin. So you need to use a thickener. So it is a nonsense because, you know, they are not easier to swallow for them. You say the other one, 3.
Yeah.
You say 3. In reality, there is not any evidence that patients with Parkinson's disease have iron deficiency, neither as part of the disease or because it's more common, the iron deficiency in them, because bleeding. So I don't see
But
any.
I read that iron shouldn't be given to Parkinson patients because high quantities of iron exacerbates more the Parkinson. So I read it through the Sanders book. So I
The
don't know if that's
high amount of iron
yeah.
exacerbate Parkinson.
Yes.
Yes, the hemosiderosis, one of the symptoms of hemosiderosis is Parkinson's, because there is a deposit of iron in the basal nucleus of the brain and can produce Parkinson. So iron can produce Parkinson if it is in excess. Yeah. So there is not a reason of including iron, high iron in the client's diet. Make sense? We agree?
Yes.
Okay. So, okay. Yes, guys. When the people have too much iron, they develop a condition called hemosiderosis. And it is frequently seen in clients with ¿cómo se llama? Hemolytic anemia, the sickle cell disease. Okay, the disease that is more common in Black people. But in any other hemolytic anemia can happen because they receive repetitive transfusion of blood. They can develop hemosiderosis because of a lot of iron, and it can produce deposit of irons in the basal nucleus of the brain that are the extrapyramidal area, producing Parkinsonism or Parkinson-like syndrome induced by the hemosiderosis, and can produce hepatic liver damage can develop cirrhosis, can produce atrophy of the testicle in men, and also deposits in pancreas that can produce ¿cómo se llama? Diabetes. Deposits in the joints can produce a form of inflammatory arthritis. So it's a very serious condition. What you said is good, but it generally is tested in clients with hemolytic anemia that usually have too much iron because they don't lose iron, and by the contrary receive recurrently a load of iron with the transfusions. And the most common question is that they need, supplementation of iron or a diet rich in iron, and the answer is no, because the risk of this. By the contrary, they receive medication like the dexferrosamine to eliminate, to sequestrate, ¿cómo se llama? Sequestrate and eliminate the iron from the body, okay? But it's an interesting comment. I saw this topic that she commented in patients with sickle cell disease and hemolytic anemia. No iron for them, no iron for them, no iron for them, okay? What about I should give my family member with Parkinson a sedative, hypnotic, when the tremors are more intense? What do you think about this?
No.
Sounds like non-appropriate,
Yeah, no.
because the tendency in nursing is to avoid this kind of medication. Why? First is keeping the client sedated and not interactive, which is the desire. So it's going to be incapacitated by the medication. It's considered a type of restraint. you know. And second, this kind of medication promote falls. That is a very risk in those clients, and have, toxicity in old patients, because usually Parkinson's is a disease of older patients. So it sounds by a strategy that it is not very convenient. So even if you don't have any idea of that, I think that eliminating the one that doesn't make sense for you, because you know that you have the knowledge that this is inappropriate, and this is inappropriate, then you need to reach the conclusion that is good. But I'm going to explain that. This is a technique, is a strategy that we use in patients with Parkinson's. The problem with Parkinson's is because the rigidity, when they walk, they shuffle. Shuffle is when you slide the feet instead of raising the feet to then land in the step forward. So people that are walking normally, they raise one foot, while the other foot is on the floor, yes? And they raise the foot. This is a normal person. A person with Parkinson is sliding, okay, the feet, okay, is sliding the feet, shuffling, yes. They don't raise the foot because of rigidity. So we can tell the client, think that okay, we use that a lot if there is how you call that, tiles on the floor, okay? So you tell the client, try to advance your foot to the next line of the tile, So this way the patient make an effort to advance the foot, trying to understand, to compensate my disproportion, to advance the foot to the tile. So this way you counter having the patient concentrated in this action, you counter oppose the shuffling, it is the way. So that's it. That's why it is a technique frequently commented in the teaching of clients with Parkinson, okay? With Parkinson. For example, there are other teachings, like, for example, ask the client to sleep in prone position, because they have the tendency of being stooping, They're always leaning forward. This is classical with the Parkinson, So if they make the patient, okay, sleep in prone position, the own weight of the body will promote a straightening of the spine. Other recommendation, trying to keep your hands clasped behind. So trying to keep your arms clap behind your body to displace, okay, the gravity, just the weight and the center of gravity backward, and trying to straighten up the walk. What else you recommend the clients? When they are freezing, when they want to start walking, they freeze. So we ask the client to balance forward and backward with the body to overcome the freezing. What else do you recommend? If they have too much tremor, in one hand, keep holding something in the hand. If they keep holding something, whatever, in the hand, the tremor decreases. So if they're grabbing something, okay? Those are strategies that we recommend those clients to trying to compensate the movement limitation they have. By the way, the diet of those clients should have increased calories, because they are working out continuously. They have an increased abnormal contraction of the muscles all time. They are hypertonic, and they are shaking all time. This produces loss of weight, and the calories are increased. But if they are taking levodopa, the dopaminergic medication, should not be taking vitamins, specifically the B6, because the B6 inactivate or antagonize the metabolism or the action of the levodopa in its transformation in dopamine. Okay, so those are some details that are good to remember in client with Parkinson. Okay. The nurse is planning a staff development conference about informed consent. Which of the following information should the nurse include? Select that apply. So what we should be answering here, okay. An individual designated by a power of attorney for healthcare can provide informed consent despite the competency of the client. Okay, you need to take care if you are understanding what is written there. What is written there is that the proxy, so the person designated by the client to decide for him or her in case of incompetence, can give consent if the client is competent. What do you think about this?
No.
The answer is no. The answer is no. Meanwhile, the client is competent. Is the client the one that is going to give consent? The advance directive are activated when the patient becomes incompetent. So those are the requirements of advance directive for healthcare that are different from the advance directive for economic purposes, okay, for inheritance and this kind of stuff. This is a concept that you need to have very clear. You can have advance directive, but those advance directives are inactive until the moment that you become incompetent. So meanwhile, you are competent, they are going to ask you to give consent. They don't go to the living will, or they don't go to the, ¿cómo se llama? The proxy. But in the moment that you become mentally incompetent is when these advanced directives are activated and then are so useful. So the answer of this is no. I agree totally with you. The law is clear in this aspect. The nurse has a duty, responsibility, to insist that the client repeat what has been said, I assume is said by the provider, no? About a procedure for which consent is necessary. What do you think about this? What is the role of the nurse in the advance, in the role of the nurse in the consent signature?
To witness it.
Witness and make sure that the
and,
patient understands.
You witness it after what? After you do what? An assessment, no?
You
Yes
witness
or
it.
no?
I think you teaching the patient about it.
You don't teach the patient. The one that gives the information is the provider. You don't give information about those procedures because you are not competent to give this information. But you give the document to be signed and you co-sign as a witness. But before allowing the client to sign, you need to verify that the client is informed. That was informed by the provider. And the client is accepting the procedure voluntarily. And the client has no doubt, no second thoughts or anything that could be needing clarification with the provider. To know if the client has been informed, need to do an assessment. Yes, because the nurse was not present in the moment that the information was delivered to the client. That maybe was delivered 1 week before, 2 weeks before. Okay, when the doctor, when the client visited the doctor and the doctor presented the situation and suggested or proposed a procedure. You understand? So the nurse need to make an assessment. After we clarify that, I don't know if I'm explaining myself. I'm not very sure that I'm explaining myself if you're understanding me. But after what I said, what do you think about 2? Yes or not?
Yes.
Everybody agree? Okay, apparently there is no opposition. I agree with you. I agree. The nurse should ask the client to repeat what has been, not everything, detail by little, but at least the general most important aspect. What do you know what surgery you are going to have? Do you know how the name of the surgery? Do you know who is going to be your surgeon? Did you receive information about the pros and cons of the surgery? Okay, you need to make an assessment because generally the information is given usually time before, and when you bring the document to be signed, is usually days, or hours after the provider, I mean the doctor, anesthetist, or whoever gave the information to the client. So you need, and you were not present necessarily. So you need to make an assessment. So you need to insist that to be sure that the client knows, okay, is informed, is properly informed, and only in this situation is when you allow, at least in theory, to the client to sign the consent. And then you co-sign that you did your assessment, you insisted in the client's repeating the most important aspects of the procedure, and the client was properly informed. No doubt, we can move, yes? So I agree with that, yes. The primary care provider must disclose the risk in the client if the client declines a recommended procedure, yes or not?
Yes.
Yes.
Very important. And it is a frequently tested point in Nclex. Both doctors and nurses need to give the information to the client of the consequences of refusing a treatment, medication, etc. So the patient has the right to refuse treatments and procedures. Yes, absolutely, no doubt of that. But must be a informed decision. So the responsibility of the nurse and doctors before accepting the refusal of a client is to give the information of the consequences of the refusal, and it's tested. So before accepting the refusal, before documenting the refusal, before the nurse calling the doctor because the patient refuses a medication, before that, your responsibility is to inform the client the consequences of refusing that. And supporting the client, you have the right to refuse, but you need to know that what can happen with this is this, and this, okay? So it is an important concept. The client should sign the consent form prior to receiving opioid, yes or not?
Yes.
Yeah.
Yes.
Yes, because once they receive medication that produces alteration of the mentation, then they are not competent. So now need to be signed by the proxy, if there is any, or the procedure need to be canceled. Informed consent is not needed for emergency procedures that are in the client's best interest. Yes or not?
Yes.
Yes. So the signed consent can be waived if the patient is unable to give consent. There is no proxy to give consent. In this situation, patient is unable to give consent, is not competent. There is no proxy to give consent. Then there is no problem. The law establishes that if the physician considers that it's beneficial for the client, the law assumes that the client would be giving consent if we're in the capacity of giving consent. And for that reason, the law supports that. So this is the way of answering that. Consent is another very important topic in Nclex. Very important. The legal part, guys, in Nclex is very important. The nurse is screening for clients who are at increased risk for developing sexually transmitted infection, STIs. Which of the following question will be the most important? So it's very important that you are aware of the superlative. The most important for the nurse to ask when screening sexually active clients, what do you think is the most important question here to determine if the client is at risk of developing STDs?
2.
How many
One.
sexual partners have you had in
4.
the past year? Okay. Okay. It is
One.
something very difficult and very
I
delicate.
think 3 is the best thing for me. At what age did you become sexually active?
Okay. I think it's a oh Lord. Okay. Very difficult to determine because you can have many sexual partners, but if you use barrier methods, okay, and you're careful, not necessarily your risk is increased. So imagine you, the person trying to count 1, 2. I just said 3. So I feel a little embarrassed, okay, asking this question in the past year. Or in my
And also past year means like a small frame of the time. How about the other years, you know?
Yes, okay. So it's like I don't see myself asking this question. I feel uncomfortable and not necessarily a very actively sexual person is careless or reckless. Maybe yes, maybe no. Do you use a method of birth control is not helping because the answer is yes or no. If it is yes and it's the pill, which is the most commonly used, it is not protective. Doesn't sound
So birth control only covers for the pill?
no.
It's not considered the barrier method like condoms and
Look
other
at this.
stuff?
Look at this. You are asking me, do you use a method of birth control? And I say yes. And this is the answer, yes or not question. It is a yes or not question. Do you use a method of birth control? Yes. Do you use a method of birth control? No. So it is a yes or not question. And the most commonly used is the pill, and the pill doesn't protect. So do you think that this is the question that gives you the best information about the risk? No. Acuérdate que you need to be in your test. You need to be, when you choose an answer, you can change it. So don't believe if somebody told you the school that don't change the answer. No. It is not true. It is false. It is false. It's proof. It's evidence of that. You can choose that, but then you need to analyze. Okay, what is the answer to this question? Yes or no?
4.
And you know, and
Number 4. 4.
you critique your option because remember those questions don't repeat in Nclex, but the strategies or the systematization, the discipline that you can develop to answer questions will repeat in Nclex and will take you for success. So you yourself, you can critique number 1. Yourself can critique number 2. Number 3 is the same. It's not helping at all. But I think that if a person has already an STD, okay, is at the risk of having other STDs. Because to catch the first STD, translate the behavior that increases the risk of catching future STDs. It's like false. What is the best predictor that a patient that you are admitting in the hospital is at risk for a fall? And you can have, the patient has unstable gait. The patient is blind. The patient is taking medication that produces orthostatic hypotension. The patient has fallen before. Yes, this is by statistics, okay, the best indicator that the patient is at the risk of falling. if the patient had a previous fall. You understand? And the same apply here and practically to everything. So those risks, if you already had, okay, the situation, the disease, the incident, the fall, etc., then it says that you're at risk for that. And this is what the statistics says, that people that have STDs tends to have, more than one STDs. That's why there are screens for everything. And I think that the best answer here is 4. I suggest to use that for STDs and use that for falls. Previous incidents is the best predictor that it can happen again. It's a difficult question. The nurse is caring for a client with Huntington's disease. You need to know what is Huntington's. Is hereditary, autosomic dominant, appears in middle age, and produces dementia and chorea, normal movement. Which of the following findings would be the priority to follow up? Read the options and tell me what you think.
Number 2.
Absolutely. This is a wonderful question. Those questions I like those questions because reality are questions that I see in those questions in your Nclex. So notice that Nclex is not testing you in this moment, in this question about Huntington disease. Now, the question is not about Huntington disease.
It's a priority.
It's a question of aspiration. In any client, not only Huntington disease. You understand? And obviously, it's a question of prioritization, and it's a question of aspiration in any client. So, in my experience, they use Huntington disease, amyotrophic lateral sclerosis, a series of diseases that are rare. You see, why Nclex is asking a nurse in their licensure test about those weird and rare diseases? Because the question is not about the disease. The question is about something that can be applied to anybody. So if any client is coughing, okay, during a meal, you need to think that is aspirating. And then you need to follow up. You need to evaluate if the patient is swallowing okay, has gag reflex, auscultate the lungs, etc., etc. The other aspect of that you see here are expected in patient with Huntington disease and has no treatment. So they have abnormal movement, they have memory loss, dementia, abnormal movement, of course, deterioration, progressive deterioration. This is what you see in patients with Alzheimer's, dementia, etc. They deteriorate progressively, lose weight, okay, failure to thrive until nature, God has a pity on them, and they go. The nurse is teaching a client who is receiving prescribed clozapine. It is a pharmacology question. It's about the medication clozapine, probably. Which of the following information should the nurse include? Read the options. It is an easy one.
One.
I couldn't hear you.
One.
One, okay. So the most important that you need to know about clozapine, which is a medication that you must know, is that it is an antipsychotic medication for schizophrenia, for cuckoo people, of the new one, the atypical, but has a very important side effect. Only this. The rest of the atypical don't have this problem. Only the clozapine that can produce bone marrow depression and can produce granulocytopenia. It can produce a drop of the granulocytes, specifically the neutrophils, and can produce an intense neutropenia. The first, it is an idiosyncratic reaction. It means it's not because it's toxic high doses. It's not because it's given with bad intention. It's not because it's aspired, whatever. It's an individual bad luck reaction. We cannot predict who is going to develop this granulocytopenia. But because this medication with certain frequency, that is part of the protocol for the patient receiving this medication to have a CBC periodically done, generally weekly, which is a pain on the neck, no? At the beginning of the use of this medication. So you need to know that. Those medication, the atypical antipsychotic, all this family have the tendency to promote weight gain and metabolic syndrome. You should know what is metabolic syndrome, okay? This obesity, the central obesity, apple shape obesity, abdominal obesity, okay, that can increase the cardiovascular risk. And the paranoia will improve instead of increasing with this medication, which is the option 3. And this medication produces orthostatic hypotension. The antipsychotics in general all produce anticholinergic is true, but what was it? Orthostatic hypotension. If you are taking a medication that produces orthostatic hypotension, I mean lowers the blood pressure when you are standing, a hot shower that is taken usually standing produces vasodilation and more hypotension, which can produce a fall, a syncope in the shower, okay, with the possible trauma. So that's why it's not correct. Hot showers produce hypotension for the people taking medication that lowers blood pressure, okay? So clozapine is important to know for Nclex. The nurse has taught the parent of a 9-year-old child who has been newly diagnosed with bacterial conjunctivitis, okay. Which of the following statements by the parent would indicate a correct understanding of the teaching? O sea, what is correct? What is correct here? Yeah, it's an easy one.
Three.
Okay. Bacterial conjunctivitis generally are gram-positive, also chlamydia, produce a purulent discharge. The watery discharge is seen in viral conjunctivitis and in allergic conjunctivitis. You can rule out this. You should rule out corticosteroid in bacterial conjunctivitis because the corticosteroids are immune suppressors and are not indicated in infections. The use of steroids can make the infection worse. So by basic concept, you should eliminate this. So you should be left between 2 and 3.
But with soap and water? No.
And well, yes.
Soap in the eye?
Yes, soapy, yeah, soapy water. Yes.
Okay. Is it soap and water?
Sí, soap and water. I don't know if you know how to bathe a client, but you know you bathe a client with the face with a washcloth.
Yeah.
And you use that. You close their eyes, and then the same way that you close your eyes, and then you clean the eye from inner canthus to outer canthus, changing the point of the washcloth, and you use soap and water.
Okay.
This is when I work as a CNA. I worked more than 5 years, and I went to the school of CNA and was examining. It included, okay, soap and water. Of course, you ask the client to close the eyes when you do that. So, you know, and yes, absolutely yes. Soap and water. You wash the face of the clients and the eyes of the clients, like in this condition, with soap and water. You don't need to use normal saline or any special shampoo or something like this. Photophobia. Okay, photophobia. Could be present, but it's not the most characteristic of conjunctivitis. So you need to choose between these two. I noticed that you were concerned about the soap, but I want to tell you, yes, soap is used to wash the face. Okay, it cannot
No,
be.
yeah, the face I understand, but it
It
didn't
includes the eyes.
specify that it was in the outside. You know what I mean?
It includes the eyes. When you are going to, the first that you do in the clients is to wash with the washcloth. Okay, I'm talking about bath. No? Is to wash from inner canthus to outer canthus. Okay, one eye and then the other, and you use soap and water. Okay, and all the face. You ask the client, and then you wipe, you rinse with clear water. It is the way that we wash the face of the clients. There are a lot of sebum, okay, oil accumulated in this area that need to be clear with soap and water. You use soap and water in the face. Of course, you ask the client to close the eyes to prevent irritation. But yes, the problem of the bacterial conjunctivitis is this. The problem of the bacterial conjunctivitis is the amount of purulent secretion that produces. Okay, is contact precaution. Okay, and requires, okay, washing with the face, okay, before administering the eye drops. It is, I remember that a question in Nclex put in order the steps to administer eye drops. And I remember in an Nclex question, the first step was to wash. They didn't say with what. Wash the eyes, remove the secretion, okay, washing from inner to outer canthus, okay? And this is the priority in that. So need to know that this is the priority in bacterial conjunctivitis, to wash before administering the eye drops. Administering the eye drops without, washing is not going to help the client. So I personally, if we were in my Nclex, and knowing that because I did that a lot of time, okay, that you can wash the face with soap and water, I choose 2 instead of 3, because photophobia is not the most important. I'm very aware of photophobia in meningitis, very aware of photophobia in migraine, very aware of photophobia in eye surgery, after eye surgery, especially cataract surgery. Okay, anadeophotophobia in case of anticholinergic medication, use of anticholinergic medication that produces a lot of photophobia, like when you go to the ophthalmologist and they dilate your pupil. This is the one that I know is important to know about photophobia, but I'm not convinced that in bacterial conjunctivitis, photophobia being, a significant issue. So I prefer going to do it because I know that it is important and frequently tested.
Prof, I have a question.
Sure.
Now that you were saying about how to clean the eyes, I saw multiple questions. I don't remember if it was in this exam, but it was saying that you clean the secretions from the inner to outside, which is correct. Another option was saying that you apply the drops and you make the client make circles. Is that true or no?
After you apply the drops, you ask the client to gently close the eyelids and move the eyeball side by side. It's important to distribute the eye drop while the eyelids are gently closed, not squeezing the eyelids, because then the drop is going, the medication is going to be squeezed out of the eye. But then you ask the client to move the eyeballs side by side. Is this what you meant?
Yes.
Okay,
Thank you.
yes, it is part of it. And remember that while the client is doing that, you are making pressure. Okay, you are making pressure in the nasal bone to pressure over the lacrimal duct, nasal lacrimal duct.
Thank you, Prof.
So summarizing, to give eye drops, you remember that for a standard precaution, because you are going to touch conjunctiva and secretion, you should be wearing gloves. Remember that you need to administer those eye drops positioning the patient in Fowler's, a high sitting, because it's the best. And then you ask the client to lean the head backward and look upward. So head backward, tilt the head or the neck backward, and look upward. With a non-dominant hand, you pull down the lower lid, making a pocket. If you have the option of watching this before everything, so you see the patient, you watch the eye, okay, and pull down. And then with the dominant hand resting on the forehead of the client, and without touching the eyelid, you allow a drop or the number of drop orders to fall in the pocket. Then you release the pocket and ask the client to gently close the eyelids and move the eyeballs side by side. Meanwhile, you are pressing over the nasal bone, okay, for 1 minute to prevent systemic absorption. And then you provide with a tissue the client to wipe any tears, whatever, and you document. If you need to give 2 different eye drops, you should wait 5 minutes between one and the other. And if you need to give eye drops and ointments, ophthalmic ointment, first the eye drop, second the ointment. The best moment to give the ointment is at night when the patient is already on bed, because the ointment tends to produce blurred vision, which is a safety issue. Those are the most important aspects, apart of what we commented of cleaning before administering eye drops if needed. Okay. The nurse in the ER is assessing a client with multiple injuries that occurs as a result of motor vehicle collision. Which of the following nursing observations should receive the highest priority? Avulsion injury of the left in the fingers. It is a serious lesion. Deep laceration on the right forearm, with blood oozing from the surface. Hematoma on left side of the neck. Open fracture of right tibia and fibula. Which one is the
Three?
white
Three.
tree?
Maybe it could be a pneumothorax.
Yeah, 3.
No, pneumothorax, no. 3 is not pneumothorax. Because why?
Comprehends the trachea.
The trachea, yes. The problem is that there is the airway, the A of ABC. The problem is when you have a trauma in your neck and there is a hematoma, you assume that this hematoma is like a tumor there, no? A tumor of blood. There you have an artery that can be easily traumatized because the neck has no bone to protect the arteries there, which is the carotid, the internal carotid. Yeah. So first, you can have a hematoma in one side of the neck because rupture of a carotid. Okay. And second, the expansive hematoma can compress the trachea, producing the A of ABC, okay, a problem to breathe. And that's why it's the priority. Pneumothorax, what you see is that the trachea without hematoma is displaced to one side, but it's because in the chest, not in the neck, there is a force that is pushing the mediastinum, okay, to the other direction. So if you have somebody with a pneumothorax, you have the trachea, okay, you have one lung, the other lung, okay. This lung is collapsed. So this is right, this is left, yes? And the pleura start filling with air and blood under pressure. The other lung is okay. But the problem is that the pressure that is building up here in the pneumothorax is pressure building up like the tire of your car. The air is under a lot of pressure. If you push the valve, it's going to say shh, because the pressure, no? This pressure is going to push the mediastinum in this direction, so to the opposite side of the pneumothorax, and then the trachea deviate, okay, to the opposite side, okay? So that's the story of the pneumothorax. No confuse that. Now what they are mentioning here is that the client has a hematoma building up here. And the hematoma can, especially the carotid, can, obstruct the airway. That's why it's the priority. The nurse has attended a staff education conference about fluoroquinolones, a family of antibiotics. Ciprofloxacin, levofloxacin, norofloxacin, etc., etc. Follow-up is required if the nurse states that fluoroquinolones, what is wrong here?
Number 3.
What kind of antibiotics are quinolones?
Big spectrum.
Broad spectrum.
Broad spectrum.
Broad spectrum.
They have activity against gram-positive, gram-negative, anaerobe, even tuberculosis, okay, TB. So they are broad spectrum. Can they produce photosensitivity? Yes. Can they be hepatotoxic or nephrotoxic? Yes. Can they be given IV or orally? Yes. Okay. So the mistake here is considering them narrow spectrum. The main narrow spectrum antibiotic you are going to be dealing are the penicillin. Narrow spectrum, are very efficient, but narrow spectrum. And few others. The nurse has taught a client who had a permanent ileostomy created 3 days ago. Which of the following statements by the client would require follow-up? Read that. Not the stomach appears swollen for 6 to 8 weeks. I should change stomach function. I should 0.1.
Number 2.
Yeah, just a moment, guys. I don't understand those measurements. 0.1 inch. 1/10 of inch to 0.3, 1/3 of inch. 0.3 centimeter. 3/10, ok, 3 milímetros. 3 milímetros to 8 millimeters. 8 millimeters too much. Okay, number 2, I should change the ostomy pouch daily. No problem with that. After the morning meal. Generally it's in the morning after the breakfast when they have the bowel movement that usually occurs. Most people have bowel movements in the morning, and it's the most usual. So they wait for the bowel movement, and then they change the ostomy or everything. So usually ostomy is changed once daily. Okay, the best scenario is to change everything once daily. So you have a wafer or a skin layer, okay, and you have a bag, attached to the wafer, to the skin layer. And the idea is to change that daily. If you are very lucky and you can keep that 2 days, you are very lucky, because generally in 1 day of use of that, it becomes loose. The bag is emptied because it has a port several times per day. The bag can be emptied several times per day, but all the stuff is usually changed once daily. You are understanding me, no? And usually you do that in the morning, because when they have the breakfast, usually they have the reflex of the BM, then now it's full this stuff, and then you take the advantage. So it is going to be a change. So I don't see the problem with 2. I think that 2 is okay. I think that this is okay. And this is okay. You never allow the bag to fill more than a half. If you allow the bag to fill more than a half, the weight of the content will promote separation, either from the bag, separation from the bag, of the bag from the wafer, or even separation of all the cysts in the wafer. So it is okay. So I can assure you, this is okay, and this is okay. Okay, this is to empty the bag, and this is to change all the ostomy okay stuff. So you need to go between 1 and 4. What do you think?
I think I'll go with 1. Because for 6 to 8 weeks to be swollen, so I don't think it's normal.
Yeah. I don't know in reality how long it's going to last, the swelling. I know that the swelling lasts more than a week, but I don't know exactly how long it's going to last. Okay, but what you know, let me define something important. When you have the stump, ileostomy or colostomy, okay, the stump, and you are going to cut you measure and you cut the hole, a hole in the wafer or the skin protecting layer that is generally something that has a glue and sticks to the skin. You know that? And can be integrated with the bag, or could be integrated with the bag, okay, or could be attached to the bag with a ring. Okay, so there are two types. There are some systems that comes the wafer, o sea, the sticker and the back joint that cannot be separated, and the other one that can be separated, can be, okay, attached with a click. Okay, and this has a port to be empty. Okay, there is a rule for the separation between the border of the stump, okay, and the border of the hole that you cut, that should be cut by the registered nurse, should not be cut by the CNA, because the assessment of the stump, the measurement of the stump, and the cutting or design of the hole of the wafer or the sticker need to be done by the RM. This distance, but you remember, what you studied is going to be this distance. Because it is too narrow, the border of the wafer will traumatize the stump, producing erosion, wound, and bleeding. But if it is too wide, too much wide, yeah, then it's going to leave exposed too much skin to the feces, and it is going to produce extensive dermatitis and skin breakdown. That's why there is a measurement that need to be respected in this little, you know, border, little band, or how you call that? Yes, that is left exposed. This little band of skin that is left exposed. What you remember of this measurement, because they are referring about it here. No, sorry, the last one. This here, okay? Because I have a problem to recognize those measurements. I learned that is 1/8 of inch, which is equivalent to 3 millimeters. This is what I know about the size of this Dios mío, ¿cómo que se dice eso? This band of exposed skin that is left there. Anybody have this memory of when you study about colostomy care or ostomy care? Okay, those are the values that I remember. I don't recognize those values. So I'm not sure the answer to these questions. I'm not sure if 6 to 8 weeks is too or much time for this stump to be seen swollen after the creation of the surgery. Okay, but I have problem recognizing those measurements in the opening. Okay, so
I think it's A because 0.3 centimeters is equivalent to 3 millimeters.
so 1/10, 1/10, 1 millimeter to 3. No, this is an inch. One.
Yeah, but allow next to it, it says 0.3 to 0.8 centimeters.
So 0.8 is 8 millimeters.
Exactly.
8 millimeters is almost 1 centimeter. Yeah.
Yeah.
So I don't recognize this value, and I don't recognize these values mentioned here. So I have problem recognizing those values. Okay. So the only thing that I can help you here is that I know by sure that the size of this area of the skin around the stomach that is left exposed should be either 1/8 of inch or 3 millimeters is the equivalence in metric system. And I don't know if 6 to 8 weeks is too much. So you have homework to do there. But I'm sure about this. You can investigate. It's important to know this. If you live
In-
a bigger size, then more dermatitis and skin breakdown. Yes, go ahead.
In my opinion, is the wrong one is number 2.
Okay, you're right. Remember that you are going to decide what you answer in your Nclex. That's okay. But I must tell you that this is changed every day. I don't know why you don't agree that it's changed every day.
But
No,
Profe,
it doesn't.
And I don't
It
know
doesn't-
why you refuse that. Usually people have a bowel movement after the breakfast, so that's why the most commonly the shift that changes the shift that changes
It's-
that is the morning shift.
It's an ostomy, and it drains all the time, and also that's why I'm saying that. And the other is like you don't change the wafer daily. You leave it at least 3 to 5 days.
Well, that's okay. I remember working as a CNA, changing that more than once because it's detached. Okay.
and to prevent skin irritation, because I read that
Yeah.
too on ostomy pouch, and because you
So-
irrigate it. So when you irrigate it, you allow time to to do all the process, and then you change it. So that's after a morning meal. That's why I number 2 as well. But I don't know. I think we have to review the ostomy care.
Okay, so let's review this question. This question has no easy answer. Need to be reviewed this topic. Okay, to reach. And please check this measurement. Check this measurement. 1 centimeter.
It's 1/8, but it's that 0.8.
This is 4 centimeters. So this is 0.8 centimeter, 1/8 of inch. Okay, and it is centimeters. So 1 inch is around 3 millimeters. So I don't recognize those measurements. Okay. So check that. Review this topic. Okay, the nurse is assessing a client who has a syncope. The client is reporting shortness of breath and weakness. Which of the following EKG strip would be consistent with the finding, with the scenario? Any idea?
I think that should be 3.
Any other opinion?
I think that the first one
I
is
think number 1, but I don't know.
the first one is an artifact when they are reading
Okay.
the EKG. There is not a big deal there.
It's
The second
an-
is a fibrillation. And
Measurement.
the fourth should be a sinus arrhythmia. So the 3 is a bradycardia. Patient with bradycardia could be the syncope sometimes.
Okay, so please recognize this EKG because it's super common question in Nclex. What you notice here, something horrible. This is horrible, yes? Terribly horrible. Everybody's impressed by this that you see here, no? But notice that the rhythm alone is a miracle. Probably the Holy Ghost descended here defibrillated the clients and returned alone to normal. Did you notice that, or you understand what I'm saying? So this horrible stuff that you see there return spontaneously, alone, without any intervention to normality. Yeah? Okay. It happens when one cable is loose, when the contact is not adequate, or when there is another machine near the EKG producing interferences, okay? And it's called artifact. And it is not the clients, it's the machine the problem. You understand? So please, try to understand what I'm saying. It looks horrible. It looks horrible. But what happened? It disappeared. And disappeared with what? With nothing? Yeah. So this is something that corrects spontaneously. This is when there is a loose cable, when there is a bad contact, when there is a very hairy patient, or when there is an interference of any other electrical device nearby. And it is called artifact. No intervention needed except to improve the connection. No intervention in the client, except improving the quality of the EKG. So tighten the ¿cómo se llama? Tighten the ¿cómo se llama? The cable, or the whatever is there, or change the sticker, etc., etc. Make sense? So learn from this if you don't know what is that. Okay, this is a ventricular fibrillation. A question: is ventricular fibrillation compatible with this scenario? Yes or not?
No.
No, because the ventricular fibrillation, the patient is dead. Okay, the patient is dead. Okay, in the ventricular fibrillation, the patient is dead. 100% of patients in VFib is going to be unresponsive and without pulse. It means dead. And they say here, the patient reports shortness of breath and weakness. Obviously, it's not dead, so cannot be this. Yeah. As you see here, is a patient that have a activity that is coming from the atriums, because it has narrow QRS. Even you can identify P wave before the QRS. So in 2 words, there is enough QRS here as to keep the patient blood flow to the brain acceptable. There is no reason for this patient to lose consciousness. It is something that is seen frequently in children, in young people. Okay, some people have this cycle sinus dysrhythmia or arrhythmia, that when they breathe in, they slow down. When they breathe out, they speed up, and then it's very frequent in children, in young people. It's a normal finding in them. You see that the interval between P and P is the one that varies, because the SA node changes down the frequency of firing, okay, depending on the respiratory cycle. But then how many big boxes are between these QRS? 1, 2, 3, 4, 5, 6, 7, 8. So obviously, what we have here is bradycardia. It's the same electric we discussed before. Okay, it's a sign of bradycardia. The problem that now they state in the question that the patient is symptomatic. So now, instead of having the heart beating 70 times per minute, okay, now it's beating like 30 times per minute. Yeah. So what happened with the penthouse? With the penthouse, this is the building. This is the building. Okay. This is the 20th floor. Okay, the 20th floor. Okay. The people that live in the first floor receive water. But then, do you think that if there is low pressure of water in the street, okay, the people that live in the last floor are going to receive water? No, because there is no pressure. You understand? So that's why the organ that is in the penthouse, living in the penthouse, is the brain. So now the brain is not receiving enough pressure, okay, because the low heart rate, the cardiac output is decreased. Why? Because the heart rate is decreased. Cardiac output is the volume that the heart spits in one contraction, the stroke volume, times the heart rate. So now the heart rate is only 30. So the cardiac output decreases. So the amount of blood that is pumped to the brain is decreased. Now the brain doesn't receive blood. If the brain doesn't receive blood, doesn't receive oxygen, and then the patient pass out. No pass away, pass out. But then once the patient brain is on the floor, especially after a big pump in the skull, the patient wakes up immediately. And this is called syncope. Why the patient wakes up? Because now the brain is in the first floor. It's not anymore in the 20th floor. Now the patient fell. So now the brain is at the level of the street. You understand? So now the blood can reach there. So if you have a patient that has syncope, this is an Nclex question. What is and the patient arrived to the ER with syncope? What is the first nursing intervention with this patient? Patient enters to the ER saying that suffer of syncope, is passing out. Yeah.
Raise the legs.
So ask the patient, make the patient adopt the recumbent position. There is no need of raising the leg because there is no hypovolemia. We raise the legs when there is hypovolemia. Why? Because when we raise the legs, there is blood pooling, accumulated in the legs. And then you move the blood when you raise the legs to the heart, to the circulation. Yes? Yes? So we raise the leg, which is called modified Trendelenburg, when there is hypovolemia, people that are bleeding, people that have decreased blood pressure because of hypovolemia, less blood, less volume in the circulation than normal. Yes. But when you have a patient with syncope, the problem is not hypovolemia. The problem is a rate that is not enough to reach, okay, the cardiac output to reach the brain. So keep the patient, okay, in recumbent position. This is an Nclex question. What you do first, then you say EKG, call the doctor, take a vein, ¿cómo se llama? Administer atropine. I'm inventing because I don't remember all the options of this question that somebody had in their Nclex. But the right answer is make the patient recumbent. Okay? Don't allow the brain to be the penthouse. You know what is a penthouse? Because maybe you don't use this term and I use a term that is a penthouse is the last floor. Yeah. The top of the building. Yeah. Yeah. So make the brain go to the street level because being in the street level is easier for the blood to reach the brain. Okay, maybe you don't know what happens when there is a low pressure of water in the high floors, that the water doesn't reach there, and you don't understand that. That's why the most important is to make the patient recumbent. It's the first that you do. After that, you get the vein, you give the atropine, you give all the rest. But the first is to prevent the client from falling again, because in each one of those falls, the patient can have a head trauma, can have, ¿cómo se llama, a fracture, etc., etc. The nurse is assigned to care for the following clients. The nurse should first care for the client who is, let's see, 3-hour post-operative, is recent surgery, is receiving PCA, patient-controlled analgesia, and is complaining of incisional pain. Maybe he doesn't know that need to push the button. Upset, and is verbalizing the need to leave the facility. Take care, but sometimes, take care, guys. Sometimes this client is the first to see. Let's see if somebody is more unstable than this, okay? But sometimes this is the patient to attend first, because also if everybody is stable, this becomes the priority. The patient that is, upset and wanted to leave the facility, and we don't know if can harm the patient. A patient trying to self-administer a bolus or gastrostomy tube, some patient can feed themselves, okay? And the feeding tube is occluded, so is clogged. Client receiving chemotherapy for leukemia and whose IV pump alarm is sounding beep beep beep. But which one you see first?
Number 4.
I agree. This is the
I
priority.
think thrombophlebitis.
I agree. I agree, because chemotherapy is a vesicant. Okay? And the problem is that not so much thrombophlebitis, because thrombophlebitis, if the catheter is inside the vein, and the liquid that is coming here is producing inflammation of the vein. Usually this is no reason. There is no reason for the machine to be beeping, because the liquid continues flowing. Is reason for the client of complaining of pain in the site of the vein. No, of course, when you assess the vein, you can see that there is a red line, a red cord, okay, with warmth. And then you say, oh yes, it is a thrombophlebitis, because the problem is when the catheter is outside the vein, that now the liquid starts, accumulating outside the vein in the interstitial fluid. Of course, it is behaving like an obstruction and then makes the machine beep. But this chemotherapy will kill the cells that are in the subcutaneous, producing a necrosis, a vesication. Yeah. And a part of that, the chemotherapy medication should be received properly, because it's something called induction, in which is important to receive the adequate dose and amount. Okay, so not for many reasons, 4 is the priority. I agree with you. The nurse is caring for a client with end-stage renal disease. Which of the following findings should the nurse follow up first? Ammonia odor of the breath, numbness and tingling around the mouth, nausea, decrease in urine output. What is the priority here?
Number 2.
What you are thinking in number 2?
Problem with the potassium.
High potassium is not felt by the client until the moment that the ventricular fibrillation appears. So high potassium, basically what produces is cardiac arrest. The other that can produce is muscle weakness, because also high potassium can be muscle weakness. But it's not typically numbness and tingling. What you say? I couldn't hear you.
Hypocalcemia.
Yes, this is what you should be thinking. Low calcium, hypocalcemia. Remember that clients with renal disease suffer of hypocalcemia, low calcium and high phosphorus. Yes. The reason for this low calcium is because the vitamin D is not activated. Vitamin D must be activated in 2 sites: the skin under the action of the ultraviolet light, and the kidneys. Those are 2 hydroxylation that should have the molecule of vitamin D. The cholecalciferol is the name of this molecule. Cholecalciferol, like cholesterol. Cholecalciferol, yes. But patient with end-stage renal disease cannot activate the vitamin D, so the vitamin D is not active. As a consequence, there is hypocalcemia. The hypocalcemia is going to, because deficiency This is called osteomalacia. 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 Okay. And bone damage and risk for fracture. But there can be hypocalcemia. If we have hypocalcemia, we can have problems. We can have neuroirritability that can produce the trousseau, the Chebostek, and can produce the tingling and numbness around the lips and in the tip of the fingers and toes, and can produce seizures, and can produce irritability in the myocardium, producing torsade de pointe. Okay, torsade de pointe, which is a BTAC, very risky. Yeah. And can also produce a spasm in the larynx, laryngospasm with a stridor, and many other consequences. So hypocalcemia is an emergency because the risk of seizures and cardiac dysrhythmias. And this symptom suggests hypocalcemia. Ammonia odor in the breath suggests uremia, high urea. Nausea is consequence of the high urea also. Uremia produces a lot of nausea. And if the patient has end-stage renal disease, we anticipate that the urine output is going to be minimum, like, like 10 millimeters per day. So the priority here is this hypocalcemia. It's true the hypotassium is an issue here, it's true, but hypotassium doesn't produce these symptoms, and they want to think in hypocalcemia, okay? The nurse is caring for a client who has metabolic alkalosis. It's vomiting or nasogastric suction, or is consuming an alkaline substance in excess. It would indicate that the client is experiencing compensation, systemic compensation, if the client has. What is the compensation of the metabolic alkalosis?
Bradypnea.
Correct.
Respiratory acidosis.
Yes. So number 3, no? So the patient will tend to retain CO2 until certain limit. So the possibility of compensation of the metabolic alkalosis is limited by the fact that there is a limit in the elevation of CO2 that is tolerated by the respiratory center. So the compensation is very partial always. But yes, the patient with metabolic alkalosis can have decreased respiratory rate to retain CO2, to compensate with the only acid that you can manipulate, which is the CO2, to compensate the excess of bicarbonate with retention of CO2. It can produce in some clients hypoxemia, but there is a limit for this compensation because there is a moment in which the respiratory center is going to override. But this is the right answer. The same way that metabolic acidosis produces hyperventilation, so increased respiratory rate, the metabolic alkalosis produces hypoventilation because this is the compensation that the patient can do. We never discussed this topic, okay? So it's something to add to your knowledge, which is not difficult because you can make this rule. Metabolic acidosis, hyperventilation. Metabolic alkalosis, hypoventilation as a compensation. The nurse has been made aware of the following 4 clients require assistance. Notice the amount of prioritization question. The same will happen in your Nclex. The nurse should first assist the client who had, which one is the most acute? Become disconnected. Complaining that the feet are still numb 2 days. spinal cord injury at T2, 2 weeks ago. It's going to affect. Yeah, that's fácil. Easy one. What is the answer?
4.
4. What are you thinking?
Autonomy.
Dysreflexia.
Yes.
Autonomy dysreflexia.
Yes. Okay, take care because usually this question is this type. They mention the level of a spinal cord injury above T6. So T2 is above T6, obviously. So once they mention that the level is above T6, start suspecting that the option is about autonomic dysreflexia. And remember that the symptoms at the beginning are non-specific, like nasal congestion, frequently in the Nclex, nariz tapada, nasal congestion, sweating, diaphoresis is sweating a lot, flushing, red, yes, nausea, headache, dilation of the pupils, piloerection, goosebumps, okay, are non-specific. But then the confirmation when you check the blood pressure, and the blood pressure is extremely elevated. Remember that it is a hypertensive crisis, and for that reason is an emergency, especially because the patient developed hypertensive encephalopathy. Is because those are usually young people. The one that have spinal cord injuries are the reckless and the young and the reckless, yes? Young people that are susceptible to hypertensive encephalopathy because the permeability of the blood-brain barrier to the lack of autoregulation of the blood flow in the brain in young people, okay? We old people tolerate better the high blood pressure than young people, okay? So this autonomic dysreflexia is always an emergency, okay? So be aware, they don't say autonomic dysreflexia. They don't say hypertension. They present this real life scenario that you have a patient with spinal cord injury above T6 that is feeling bad. And then you need to suspect autonomic dysreflexia and rule out this condition. The nurse is talking with a client who has coronary artery disease and is receiving prescribed aspirin. The client asks the nurse why aspirin is prescribed. Which of the following response by the nurse will be appropriate? It's fácil. Okay, you need to find. Okay, easy one. So what is the answer? Quickly, very fast.
Number 3.
2.
Is an antiplatelet aggregation, yes? So it's prevent the adherence of the platelet among them and with the walls of the arteries or the plaque, okay? Preventing the first step of the formation of a thrombus in an artery. Good. That's why antiplatelet medication or antiplatelet aggregation medication like aspirin, clopidogrel, etc., are used mainly in arterial obstructive diseases. The nurse is caring for a client who has a prescription for morphine sulfate 10 milligram, IV every 4 hours, PRN, to be administered over 5 minutes. After diluting the medication in 5 milliliters, 0.9 sodium chloride, how many milligrams per minute should the nurse administer to the client? What is the answer to this question?
2.
Everybody agree? Guys, this question is more or less like what color the white horse of Napoleon, okay? So a lot of distractors, okay? It's just to see if you are able to identify the pertinent information. The order is 10 milligrams, but must be given in 5 minutes, okay? and they're asking how many milligrams per minute, per 1 minute, is 10 divided by 5, 2 milligrams per minute. So this is a distractor. This is a distractor. This is a distractor. This is a distractor. Okay, so all those are distractors. Just to see if the order is 10 milligrams to be passed in 5 minutes, this is the only interesting information. Okay, as in our trainings said, the people that that write for anchors, most of the calculation questions that are evaluated, that are graded in anchors, are done without the need of the calculator. This is what they say. The nurse has attended a staff education conference about clients who have the skin wound shown below. It is a cave. Okay, it is a tunnel. Which of the following statement by the nurse would indicate a correct understanding of the conference? So obviously is an important wound. Looks like an ulcer. Probably a chronic ulcer. If it is a pressure ulcer, it is an stage 4, obviously, because it's beyond the subcutaneous, it's reaching the muscle. So what of this option is correct? No, see, correct of these 4. The client should be represented with okay. So our best strategy, rule out what is nonsense. Okay, this patient every 2 hours? No. Every hour, every half an hour. Okay, it is a patient that needs to be repositioned more frequent. 3 hours is too much time. And peroxide is a no-no in wound care. Peroxide is a no-no in wound care. Peroxide cannot touch any live tissue. Can touch instruments, can touch maybe scabs, but never a live tissue. So can be ruled out. So now you need to work with 3 or 4. What is better from 3 or 4?
Number 3, to promote healing.
I agree. This is the one that I should select if I were taking it, because there is 0 minute over this. The patient should not be resting over the wound 0 minutes. So if it is in the sacrum, for example, the patient can be prone, the patient can be semi-right lateral or semi-left lateral, but never supine, because 0 minutes over this wound, okay? Because 30 minutes of pressure over the granulation tissue that should be growing there is enough. There should be granulation tissue growing there is enough to traumatize the granulation tissue. So obviously 0 minutes. So I disagree with this. So the best option is give more protein, more vitamin, more supplementation, okay, to promote the healing, to promote the growth of the collagens and etc. I agree with you. The nurse is caring for clients who are receiving prescribed oxygen therapy. It may indicate equipment malfunction and would require immediate intervention if the client who is receiving oxygen via a non-rebreather mask has a humidifier that is filled halfway with steady water. Partial rebreather mask has the back deflate during each inspiration. Face mask has the oxygen flow meter at 6. Nasal cannula has a pulse oximeter at 93. Okay, what is the situation that requires immediate intervention?
Two.
Any other opinion?
Number 1.
Non-repeated mask has a humidifier if you have weight. No, you don't need to put a new one because you have half bottle filled. So it means that that the bottle of the humidifier, this bottle with water that is connected to the valve, okay, to the valve, okay, no, me lo puse mal, that goes here, can have half filled with water and still can be left there. So it is okay. I don't see problem with number 1. So he's saying number 2. Any other opinion? Do you feel that it's okay to have 93% in a patient that requires oxygen?
No.
No.
It's okay. Because if the patient had 70, 80, and now with oxygen is 93, the patient is okay, so it is correct. Make sense? It's good. Okay. So you can have a patient, I don't know, with a severe pneumonia, having 80%, having 75%, you give nasal and you raise that to 93. 93 is okay. 90 above 90 is okay. Okay, is okay. So it is not. Okay, so now it's between 2 and 3. A face mask can have 6 liters per minute. From 6 to 15. Yes. So I agree. Is number 2. What we know about this? What we know about this? A person who is using a partial or non-rebreather mask, okay, a person that is having, okay, a non-rebreather mask. I'm gonna change the color, okay. So the mask is covering the mouth and the nose and has a reservoir, a bag that is connected to the source of oxygen, no? So this bag, when receiving the oxygen, okay, should feel inflate like a balloon, okay, inflate with the oxygen, should be inflated, no? Yes, but when the patient breathing, this bag should not collapse, should not deflate, should not empty totally, should not be totally, okay, collapse. Need to be left half filled, okay? So if there was full filled, okay, when the patient is breathing out, when the patient breathing should be half deflated. Always should be a remaining, a remnant of half oxygen left in the bag. If you see that the bag deflate totally during each inspiration, you need to increase the liters per minute. So if you had this here you have 6 liters per minute, and you see that the bag totally collapse, okay, during inspiration, you need to increase that to 8, to 10, to 12, to 15, to whatever is enough to keep the bag half deflated during inspiration. Please know that is important. Is the way that you know how many liters per minute is going to be set below for rebreather, non-rebreather, or partial rebreather mask. It's clear. Can I move? Yes. Okay. The nurse is preparing to admit a client who has rubiola, measles. Which of the following infection, trying to mute your microphone, we're hearing your, which of the following infection control precautions should the nurse implement? Only for the client. Okay, easy one. What is the answer?
3.
3. Measles, okay, my chicken had TB is airborne, and airborne requires negative air pressure room. Yeah, the others are not indispensable. Everybody agree, no? Okay. And to enter this room, N95 is what you need. Perfect. The nurse has received the following information about assigned client who have had surgery within the past 8 hours. The nurse should first assess the client. Okay, which one is more unstable? Diabetes type 1. What the remaining of the food also is reporting feeling thirsty and had the blood sugar 160. Who had a pulmonary lobectomy, has tidalling in the water cell chamber of the closed chest drainage system, repression of 20. Who had a transurethral resection of the prostate, had pink tinge urine and has a blood pressure 160/70 with hyperthyroidism, has an inguinal hernia repair, is reporting feeling hot. And the pulse is 100. Okay, what you choose, guys?
4.
Everybody agree?
4.
4 is the most unstable. The other are more stable. The diabetic, the next concerning is the number 1, the type 1. Always type 1 is concerning because, you know, it's the most labile, the most unstable of those on diabetes client. But it still doesn't mention anything about ketosis or acidosis or hyperventilation, only thirsty and, you know, moderate elevate of the blood sugar. The water seal chamber, is working properly, so it's okay. And the TERP is having adequate blood pressure and adequate color of the drainage. So obviously, number 4, this is a patient that seems to be decompensated and has the potential of developing a thyroid storm because maybe is hot with fever and obviously has tachycardia. So it's evidence of that is decompensated. Patient with hyperthyroidism decompensate with these situations, the surgery, etc. The charge nurse must transfer a client from a locked psychiatric unit to an unlocked unit in order to make a bed available. Okay, so a patient that is a psych patient that is very unstable must be admitted in the locked area, and a patient that is stable psychiatrically stable should be moved to a regular floor. Which patient is the best to transfer? So you need to choose the most stable client.
Number 3.
Everybody agree with number 3?
Yes, number 3.
Okay, I agree also. Okay, the patient that is more stable here is number 3. It's a patient with schizophrenia, which is a chronic condition that is not showing acute decompensation. It's just withdrawn. It's a characteristic of them to be withdrawn, withdrawn from social interaction, flat affect, etc. And is requiring, you know, CNA care. Okay, so as assistance in ADLs. So the dementia clients is delusional, is having paranoia, so is active. The bipolar is is a million. And the depression is concerning the sudden change of mood. Remember this scenario, guys. When you have a patient that is depressed, it starts becoming too active, too animated, too elated, suspect that have decided to commit suicide. Is the classical presentation. The nurse is caring for a client in the first stage of labor. First stage, is the labor the longest. And observe that a segment of the umbilical cord is visible in the vaginal opening after rupture of the client's amniotic membranes. Which of the following actions should the nurse take? What is the answer? Yes, the one that is marked here. Assist the client to a knee chest position. Knee chest position. The only alternative option here is place the client in Trendelenburg, okay, left lateral Trendelenburg, but rarely mentioned. The introduction of the fingers to push the presenting part away of the presenting cord cannot be done by the entry-level nurses such as you. So you or we will have probably this option as the best answer in your English. The nurse is caring for a client who has hysterectomy 24 hours ago. Doesn't say the age. The client is sitting alone and appears tearful. Which of the following would be an appropriate response for the nurse to make? Like me to call this advisor to tell me you're so sad to talk about information. Okay. Okay. Therapeutic communication. What is the best statement here? The most therapeutic?
Number 3.
Everybody agree? I think that is the best also. Number 1, it is discarded automatically because any word here say that the patient is religious or what religion belongs the belongs the client. So this automatically is disposed. This statement is inadequate. Is going to be embarrassing for the client. Is going to be it's not therapeutic. Okay, and I want to continue describing why it's not therapeutic. And you don't give information about the surgery because you are not a surgeon, and this information will be given before the surgery, not after the surgery. So number 3 is the best option. Is the one that is allowing the patient to talk if they want to talk. Good, I agree with you. A client who had a transurethral resection of the prostate has an indwelling with urethral catheter and intravenous infusion in place. So a Foley IV. The 36 hours after surgery, the client complains of abdominal pain and has a urinary output of 25 milliliters within 1 hour. Which of the following should the nurse do first? What you do first? First, provide the client 200 milliliters oral fluid to check the flow rate and intravenous infusion. Administer prescribed analgesic. Irrigate the client bladder with a prescribed irrigant. This question is tricky. What you do first? Decrease urinary output, TERP, no CIV, and IV infusion in place. Pain. Pain and possible obstruction.
Maybe number 2 because the IV is blocked or something. It's not irrigated. It's not dripping properly.
Okay, but notice that is IV, is not irrigation.
No. Yeah, that's what I mean. It's not irrigation, but it's dripping.
Okay, it's an IV drop.
It's not passing. It's not passing the fluids.
Profe, the 25 ml per hour is too bad?
Is bad. It's not good. It's not good. This patient is having a low than expected urinary output. There could be two possibilities. One could be dehydrated. Two could be obstructed the Foley catheter, you know, because in 1 hour, maybe at the beginning it passed some milliliters, but then later it stopped, you know, flowing because it's a clot obstructing. So the question is super tricky. So you have a patient that one, have pain, has abdominal pain, yeah. Second, has a TERP that is not receiving CVI, so is not receiving irrigation. But now, in the last hour, the urinary output has been less than normal. Yeah. So now the combination of abdominal pain and decreased urinary output brings the possibility that the patient has obstruction with clots of the Foley, yeah, producing the urinary retention, the decreased urinary output because it's not coming out, it's staying in the bladder. That's why the bladder is distended, producing a spasm. And that's why the abdominal pain and decreased urinary output is a possibility. The other possibility is that the patient has the pain just because of the surgery and the patient is dehydrated. Okay, is dehydrated is another possibility. That's why the decreased urinary output. The pain is difficult to explain. And it's important to verify that is receiving the IV and on time. So, ay, Dios mío, esta pregunta
Don't we have to control the pain first and then figure it out why the patient only has?
That's what I'm thinking. That's what I've been thinking. But you need to take care, a lot of care. You need to think very well, very carefully. It is a tricky question. It's a question that you need to dedicate time. Okay. If you are in your Nclex, notice that it's not an easy one. It's not one that you can eliminate options. Okay, you cannot eliminate easily options that are wrong because notice that any option is correct.
Professor, maybe by finding the cause of the pain, we can answer the question.
I think that the most important assessment is the cause of the pain.
Meaning that if the patient is not urinating, there may be an obstruction.
Probably. Okay.
So I think I would take 4.
Do you recognize that the question is tricky?
Yeah.
Yeah.
It's a difficult question. Okay, it's a difficult question. So we have two possibilities. We have a catheter obstruction, which is very probably because the clots that usually forms after this surgery, producing acute urinary retention and abdominal pain. But also, we need to rule out the possibility that the patient is hypovolemic because, okay, there is a failure. So the only assessment that we have here is number 2. Check the flow rate of the intravenous infusion. If we go to assessment, is the only assessment because for irrigation is supposed to be an intervention to be done after an assessment that verifies there is a bladder distension because acute urinary retention, and you verify there is no urinary flow because of obstruction, but there is no any assessment of the bladder or assessment of the catheter given here. What makes the question difficult, because the easy question of this, you check for kinking in the Foley or you check for a presence of obstructive clots in the Foley. And then what you do, you irrigate. Or you evidence, you assess for bladder distension. Or you do a scan of the bladder. It's not there. It's not there. So the only assessment given here, check for the flow rate of the IV infusion as if it were a dehydration. But you know, the dehydration doesn't explain the pain.
Yeah, that's what I think. Yeah.
Okay, but it's tricky, it's tricky. You know, This is the question. Remember, you don't need to have 100 in the test to pass the NCLEX, okay? And if you give the analgesic before doing the rest, of if you check the blood, the IV rate before doing the rest, or if you irrigate the bladder before doing that, you don't kill the client. Whatever you do here, you don't kill the client. You don't need necessarily, so because you need to go to certain comfort or self-confidence in the test, that you don't need to get 100 to pass the NCLEX. By the contrary, how many students I had that passed with 75 and they have committed mistakes, evident mistake in the answer. They recognize the committed mistake by the book, no by whatever. But this question is tricky. Okay, it's tricky, but I don't care. I don't feel scared with this question, no matter that it's tricky. Okay, but in reality, it's a difficult question. Irrigation of the bladder is an intervention that should be done, but preferably after verification through assessment that the bladder is distended and not empty. Because if the bladder is distended, we know that is obstruction, which perfectly explain the pain and the decreased urinary output because the obstruction, and the intervention is the irrigation. But the problem here, they are not giving me information about if the bladder is distended, and no option to check if the bladder is distended. If the bladder is not distended, then I need to think that the decreased urinary output is consequence of fluid volume deficit or hypovolemia. Maybe because the patient is not receiving the IV infusion as expected, because is then the checking for the IV infusion, it could be the next step if the bladder is empty. Yeah. So, oh, Dios mío. So what is the priority here? The pain?
Yes, number 3.
The
For
pain,
me, is to put
the
the patient
fluid volume
comfortable.
deficit, or the obstruction? So now you have this conundrum. The question is a question that I don't see this question in the English. I don't see this question in the English as an evaluative question. Personally, is my opinion. Of course, I'm not a person that have the last word. I'm not a person that knows everything, but I don't see this question in English. But if I were in English, just by instinct, because I'm very confused, because I insist, I need an assessment to know what is happening. I don't know what is happening. I need an assessment, but the assessment that I need is to check the bladder for distension. If it is distended, it is obstruction, is the explanation of the pain, and I should irrigate, but after the assessment. If there is not distended, I should suspect, ¿cómo se llama? A hypovolemia, and then I need to check for failure in the IV infusion.
Professor, maybe in this question, maybe we should go like the other student says. We should go for the first for the pain, and then if we had assessment, we do an assessment.
And defending because it's the one that I go by instinct to choose if I were in the English. Okay, I go to the pain. Moi, but I'm not sure. I just defending what is the rationalization of this question. That because the question is tricky, the question should be about assessment, because nobody knows what is happening. And when we don't know what is happening, we should do assessment. But because they are not giving the options of irrigating or checking the IV infusion, because before that, I need to determine what is happening in the bladder, okay? I need this assessment. I'd go by instinct and by elimination to administer the prescribed analgesic. That is the only positive, situation that has been assessed, and we know what is happening. Okay, so summarizing, trying to make you understand that what should be a philosophy answering question. When you don't know what is happening, you should not action, intervention, not knowing what is happening. Irrigation the bladder requires previous assessment that verify a distension of the bladder, which is a perfect situation. Okay, the bladder is distended, the catheter is obstructed by a clot, I need to irrigate to dislodge the catheter, but it is not given. I don't have the proof to go to irrigation. The other possibility, the patient is oliguric because the patient is dehydrated. Okay, I need to support that. Again, checking the bladder. Is empty, the bladder. No urine production, the bladder is empty. No urine production because the patient is dehydrated. Okay, go to check the flow rate of the infusion. Okay, but the problem is that I don't have the information about the bladder. The only information that I have objective is that the patient is in pain. Notice that 1 and 2 are very similar because, if the patient, unless the patient is NPO, I can offer oral fluids to the client. Unless the patient is NPO, is not mentioned there. If the patient is NPO, I don't expect the patient more than 1 day, 36 hours after surgery to be NPO. So 1 and 2 is more or less the same because both are addressing dehydration. So that's why I don't go to 1 and 2 because for me it's the same. So for all those reasons, I go to close my eyes and, play the lottery, and I go to administer the prescribed analgesic. This is at the end, after analysis, the one that I choose if I were in my Nclex, for the reason that I explained. But what is needed here is an assessment, but they are not giving me the adequate assessment option. The only intervention that can be done based on the patient is in pain is give pain medication because it's prescribed and the patient says that he's in pain. And whatever the patient says is true. That's it. Is that the way of analyzing this question? It's not teaching too much this question. It's a question that doesn't teach too much. The nurse is preparing to administer the prescribed antipsychotic medication to a client. They don't say which one. Which of the following findings would be a priority to follow up? Is it antipsychotic? They don't say which one, but then which of the following, when you are giving the antipsychotic, is the priority to follow up? Lip smacking, photosensitivity, orthostatic hypotension, dry mucous membranes. What is the priority here?
1.
Everybody agree?
Yes.
I go with 1 also. Lip smacking suggests tardive dyskinesia. One of the priorities, not because it's immortal, is because it's irreversible. If it is not recognized in the earliest stage in which lip smacking is the initial manifestation, then the condition, which is an adverse effects that is consequence of giving antipsychotic, that requires discontinuation of the antipsychotic or important reduction of the dose. But generally discontinuation and changing for other. So photosensitivity is expected. All the antipsychotic give photosensitivity. I will say, cuckoo people don't go to Bahama, because it was a question that what need to be followed, a heavy question, what need to be followed in a patient that is taking antipsychotic. I'm going to take a cruise to Bahama. And we made fun of this question. Cuckoo people don't go to Bahama. Okay, because the photosensitivity. You are supposed that you go to Bahamas, you are going to be exposed in the cruise, you are going to be exposed to the sunlight. And the antipsychotic, okay, produce photosensitivity. So cuckoo people don't go to Bahama. Orthostatic hypotension is also produce the antipsychotic. I mentioned that before. No? So it's anticholinergic and produce orthostatic hypotension. So you cannot avoid, when you're taking medication that produces orthostatic hypotension, you cannot avoid the orthostatic hypotension. What you need to teach the client is to change position slowly and to anticipate the orthostatic hypotension and to avoid the hot showers, as we mentioned before. So it's not an issue because, you know, it's expected and has anticholinergic activity. I also mentioned that before. So dry mucous membrane is expected. So this is expected. What is not expected is this complication that occurs just in few of the clients taking antipsychotic, the tardive dyskinesia. Tardive dyskinesia, okay, is an important complication of antipsychotic that requires intervention, because if it is not recognized early, it becomes irreversible. There is new medication for tardive dyskinesia now in the market. There are nice commercials in TV about tardive dyskinesia that if you see those, please pay attention to the commercial because it's are very educative. The nurse is caring for a client with BPH, benign prostatic hyperplasia, who had an indwelling urethral catheter removed 6 hours ago. Which of the following findings by the nurse would be a priority to follow up? Palpable bladder with an urine output of 100 milliliters. Oral fluid intake is more than urine output. Elevated blood urea nitrogen. Burning upon urination. What is the priority here? Okay, let's go to the elimination. Burning upon urination is expected because 6 hours ago was removed a Foley catheter. So there is always the sensation after removing the Foley catheter. Of course, we need to observe the urine for cloudiness or fever, etc. Just thinking the possibility of infection, but this is expected. We can eliminate that. Okay, oral fluid intake is more than urine output. So the patient drank 1 liter and peed only 500. Okay, it is okay because you need to adhere the insensible losses, and maybe the patient is with fluid deficit. So this is not an issue that requires follow up. So if you drink more than you pee, probably it means that you need fluid, that you have a little dehydrated. But don't forget that the only output that you have is not only the urinary output, you have also the insensible losses. So usually you drink more than you pee because you need to drink for what you pee plus the insensible losses. So it is okay. Yeah. So now you need to be between 1 and 3. Elevated BUN, unless the patient is dehydrated, and there's nothing here that say that the patient is dehydrated, suggests renal failure. Yeah, so this suggests renal failure. And palpable bladder should not be palpable. Okay, the urine output is not my problem because they don't say the time, but the palpable bladder suggests urinary retention, so that the patient is having, the patient is still peeing, so the patient is not have a total urinary retention, have an increased residual, increased post-void residual. So you have an increased post-void residual, the patient is not emptied completely the bladder, and the patient could have renal failure. What is the one that you consider the priority?
3.
Number 1.
The renal
Number
failure or the increase, the obstructive outflow that produce increased urinary residual. So some people say 1, some people say 3. what is more priority? That the patient is producing the urine, but only part of the urine is leaving because there is a prostate that is obstructing. Okay. The patient is peeing. The patient is peeing, but is retaining urine in the bladder. That's why it's palpable. So increased residual, which is not good. And the other is the patient has evidence of renal failure, but they are asking which is the priority. So it is the actual problem is the renal failure. What do you think, guys?
But for the renal failure, shouldn't we have the creatinine level as well in order to
Okay,
make
but
sure that
it's not. They are only giving you the BUN. The question is you cannot change the question. Okay, suppose that it is somebody in our family, okay, that have the BUN in 40. We don't have creatinine, okay, and is having, the only thing that we know that has benign prostatic hypertrophy, and they removed the Foley 6 hours ago, and the patient has BUN 40. In seconds, the bladder is palpable. No matter that the patient is peeing, there is urinary outflow, is eliminating urine, but it's not totally emptying the bladder. So there is obstruction of the urinary outflow, and there is an increase post-void residual. Okay, so what is the priority here? What is the actual problem of the client?
The urinary retention.
Okay, I cannot I cannot decide with support, okay, from one and the other, but my tendency is to give more importance to the renal failure that is a new finding, is a new onset renal failure because it's not mentioned here, okay, versus the non-problem that is the benign prostatic hypertrophy already diagnosed, that in some way is characteristic of the disease, the obstruction of the flow. Okay. I think that the complication, the unexpected, the patient is having renal failure. Because you have an abuelito, you have myself, I have BPH, I have problem peeing, and I never empty my bladder. But my BUN is normal. I don't have renal failure. Now I develop renal failure. I think that my priority is that now I have renal failure. See? So in some way, it is expected. It's not normal, but it's expected. But this is the surprise that the patient is having renal failure. So I don't know if you consider something that is like not too important or expected that the patient develop renal failure as a complication. Okay, so another question to decide, okay, to discuss, okay, you need to take the decision in your test, okay, but you need to choose between renal failure and what you give more importance, that the patient is having renal failure or the patient is having increased post-voidal residual. That no matter that is peeing, is urine left there because it has BPH, something that we already knew that they have BPH. Okay, well, I leave that for you, the decision. One more. The nurse is assessing a 7-month-old client with tetralogy of Fallot. Which of the following findings would be consistent with the diagnosis? But of these four is consistent with Fallot.
Four?
Of course. Okay, there is no discussion here. Fallot is the one that you know that produces cyanosis.
Yeah.
And produce the cyanotic spells when crying, feeding, drawing blood, etc. And need to be placed in which position?
Chest position.
Knee chest position or squatting position. Yes. Okay. What condition produces absence of femoral pulses?
Aortic quotation.
Quartation.
What, profe? What condition?
I'm writing that. How are your glasses? Your glasses. Quart C. It is a C.
So I'm doing my best. I'm driving and I'm looking at it.
No te vayas a matar. Aortic quartation. No, ni se te ocurra. Aortic quartation, quartación de la aorta. Aortic quartation. It is a congenital disease of the aorta, in which the aorta, after the arc, has a narrowing. So the arteries that go to the brain, the carotids, and the arteries that go to the upper extremity, the arms, are not affected. But the arteries that go to the abdomen and to the lower extremities are affected and have lower pressure. So that's why if you have babies, when you take your baby to the pediatrician, they always palpate the pulses in the groin, the femoral pulses. Is because this is not a rare malformation and is frequently non-diagnosed at the moment of birth. And just palpating the pulses, the femoral pulses, arterial pulses, you diagnose that because you know the pulses are very weak or absent in the femoral arteries, while are present in the arteries of the upper extremities and the carotids. This is aortic or aorta quartation. The machinery like heart murmur. Anybody know what kind of condition is this?
Is the Panten ducts arteriolis?
Arteriosus. Arteriosus. Okay, the patent ductus arteriosus. You know that when we were in the belly of our mother, our pulmonary artery was connected with the aortic aorta, and this duct must close at the moment of birth when we started. Okay, it closed, but some babies don't close that. Okay, yes, when we expand the lungs, okay, and decreases the resistance, the circulation, the pulmonary circulation, it start closing. And then the other stuff is the drop of the prostaglandins when they cut the umbilical cord. So these two phenomena makes these ducts to close immediately. I always say that the change of the circulation of the baby from uterus to outside is like a transformer. Those movies in which the cars transforming people, etc. Because everything changes in minutes. In minutes, everything happens. Okay. Okay. This and this is the same. So is the same. This and this is the same. So 3 and 1 is the same. Machinery like murmur is the patent ductus arteriosus. Okay. Okay, guys, this is what I have for you today. Okay. There are a lot of questions now. There are a lot of questions to discuss thanks to to Mayra, okay? Because I have more questions there. So we continue. Guys, those questions are very good. I like those questions, so that's why I will continue, practicing those questions. I promise you that those questions can help you in your English. Okay? So nos quedamos en este. Okay.
Good night, profe.
Good night. Okay.
Thank you,
Thank you,
Professor. Good night.
Professor.
Bye-bye. Bye-bye. Estudie mucho. Aortic and el fallo. Fallo. Nos quedamos en el fallo. A ver, esos son. Nos faltaron un.
Profe, ¿qué usted cree que sea mejor, Ural o Kaplan?
Yo prefiero Kaplan personalmente. Ural es muy básico. Pero no es malo, es bueno, no es malo, pero no es suficiente. Yo prefiero Kaplan porque Kaplan es estadístico, te frustra, te sientes totalmente frustrado cuando lo haces, pero te enseña mucho. Así como hicimos hoy, que muchas cositas aprendimos, cosas que incluso hay que investigar después, como Kaplan te entrena mejor, que me gusta más, porque tengo muchos muchachos que han fallado, han hecho U-Word y entonces vienen a mí, ayúdeme, porque hice U-Word como 3 veces y no me ayuda. Sí, porque U-Word es bello, es muy lindo, pero es muy básico. Estas preguntas de pensar y de legal, esas cosas no son tan buenas en U-Word.
Ok, profe, gracias. Gracias, profe.
Bye, good night. No, eso no es. ¿Qué dice? Esta sí es. Ok, ahora sí.